Good morning, everyone. My name is Wang. I'm from University of Texas, MD Anderson Cancer Center. I would like to thank the Pancreatic Biliary Pathology Society and the Pdag for inviting me to give this talk. The title of my talk is Approach to Neoadjuvant Treated Pancreatic Ductal Adenocarcinoma. In my talk, I will cover the following areas. First, I will give a brief overview of the historical changes of treated Pdag. Then I will discuss grossing, sampling, and tumor size measurement according to the recently published white paper from the Pancreatic Biliary Pathology Society. Then I will discuss tumor response grading, followed by conclusion. As we all know, the current NCCN guideline recommend neoadjuvant therapy for the following groups of patients. First group is high-risk resectable Pdag patient. The second group is a patient with a borderline resectable Pdag. The last group is selected patients with locally advanced diseases. So this is why we see more treated pancreatic ductal carcinoma cases in our daily practice now. So what are the potential benefits of neoadjuvant therapy approach? Compared to adjuvant therapy approach, neoadjuvant therapy approach is better tolerated by the patient and provide early treatment for micrometastases. The neoadjuvant therapy approach provides a time window of 2 to 4 months to observe tumor biology while giving the patient the treatment. Based on the patient response, the patient was selected for surgery. In this way, neoadjuvant therapy approach select the patients who may benefit the most for surgery. The neoadjuvant therapy approach also have the potential to reduce the tumor volume and increase the likelihood of tumor resectability, and also increase the rate of complete resection. The pathological evaluation of treated Pdag cases are often challenging. This is because of several factors. First, there is no systemic and standardized grossing and sampling protocol for pancreatic specimens for treated Pdag. The second is because the fibrosis induced by treatment often are severe and extensive both in the tumor and in the adjacent pancreas tissue. So the fibrosis often make tumor identification and tumor size measurement extremely difficult. The pancreatic cancer also often show microscopic invasion into the adjacent tissue beyond the grossly appreciable tumor area. So this microscopic tumor invasion can only be identified by generous sampling of the tumor and adjacent pancreas, adjacent tissue. Lastly, there's no universally accepted grading system for tumor response to neoadjuvant therapy. So let's look at the histological features of treated Pdag. This slide shows two representative treated Pdag cases. There are several things you can appreciate from these cases. First is the reduced cellularity. If a pancreatic ductal carcinoma shows response to neoadjuvant therapy, the first thing you observe is reduced tumor cellularity. Second, you will notice the hyalinized fibrosis, which is a common feature you can see in the treated pancreatic ductal carcinoma. Lastly, you can see there is a heterogeneous response in different areas of the tumor in both cases. So there are some areas you can see near complete response, while in the other area, you may see little or even no response at all. From a cytological aspect, the treated Pdag can show clear cell changes as shown in the left-hand panel. They can also show intracytoplasmic vacuoles, sometimes with eosinophilic globules. The tumor cells can also show the eosinophilic changes in the cytoplasm. The nuclear may show pleomorphism, hyperchromasia with degenerative and smudged nuclei. In the other cases, the treated Pdag may show this large cystic dilated glands. The tumor lining is attenuated due to the dilatation of the cyst. In some cases, this tumor gland may mimic the benign pancreas cyst. So sometimes you can also see mixed order stroma changes in the treated Pdag cases and necrosis or mucin pores in the stroma. So this slide summarizes cytologic changes and stromal changes of the treated Pdag as I showed before. But I want to tell you, 9 of these features are specific for treated pancreatic carcinoma. You can see all these features in the untreated pancreatic carcinoma patients as well. So I want to give you one example. This is a case which is untreated pancreatic carcinoma, but you can clearly see there's a hyalinizer and the mixed order stroma with forming cellular changes. But this clearly overlapped with treated pancreatic carcinoma on histology. So can a pathologist reliably differentiate treated Pdag from untreated Pdag based on histology alone? The short answer is no. The recent study from the International Study Group of Pancreatic Pathologists showed that the sensitivity to differentiate treated Pdag from untreated Pdag is 76%. The specificity only 49%, which is essentially a flip of coin. In the treated Pdag cases, you can also see intraductal carcinoma, which is also called cancerization of the pancreatic duct. So the recent study from Johns Hopkins showed that this intraductal component is less responsive to the tumor than the tumor cells in the stroma. In their study, they showed that in the neoadjuvant treated group, the proportion of intraductal carcinoma is 12.7% compared to 1.9% in the untreated group. So this is statistically significant. The histology changes in the adjacent pancreas also similar to the tumor, which often shows this hyalinized fibrosis with lobular atrophy and the loss of acinar cell component. And this atrophy is often severe. In some cases, you can see this aggregation of the longitudinal islets due to the loss of acinar cell component. We did a study a few years ago to compare the non-neoplastic pancreas tissue between the treated and untreated pancreas cases. What we found is the following. The treated pancreatic group has more severe fibrosis, more longitudinal islet aggregation, and more neuronal-like nerve proliferation, but less severe inflammation compared to the untreated group. Our study also showed that the frequency of pain 1, pain 2, and pain 3 lesions are similar between the two treated and untreated group. However, the pain density are lower in the treated group compared with the control group. So this was published in the Histopathology in 2013. So now I'm going to move forward to discuss the recent white paper from the Pancreatic Pathologists Society. I want to mention that before the discussion that this paper has been posted online to all members of the Pancreatic Society for open voting and comments. And during this process, we receive overwhelming support from our members. We totally received 51 votes from 228 members. 92.2% voted yes, and conceptually agreed with the consensus statements and the recommendation. Only 7.8% voted no. We thank the members for their support of this work. So the first recommendation from this paper is a systemic and standardized grossing and sampling protocol should be adopted for pancreatic specimen for treated Pdag. This recommendation seems to be a no-brainer. However, currently, there's a lot of variations in terms of grossing and sampling among different institutions. So we feel that this is important as one of the major recommendations from this paper. So as we all know, the current AJCC staging of the tumor stage is for YPT1 to YPT3 is purely based on tumor size, ranging from less than 2 centimeter to 4 centimeter and that more than 4 centimeter. So as a tumor, as a staging. The tumor size measurement in a pancreatic neuroendocrine tumor can be easily done based on the gross measurement. However, for the treated pancreatic carcinoma, here I show 3 different cases. You can see the fibrosis in the tumor and in the adjacent pancreas often merged to each other. It's very difficult to determine where the tumor starts, where the tumor ends. So this is why the current AJCC, current CAP kind of protocol and the guideline for from the ICCR recommend that the tumor size measurement have to be validated by histology for pancreatic ductal adenocarcinoma. So how we do that? So this is recommendation number 2. Consecutive mapping sections along the largest gross tumor dimension are recommended to validate the tumor size by histology. So this is an illustration of a Whipple specimen, and it shows the illustration showing the mapping sections along the largest dimension of the possible tumor. So once you review the histology, you can reassemble the histology slides and measure tumor size based on the histology. In this particular case, a tumor size is 3.3 centimeter. So how we do that in Anderson? At Anderson, right now we are using the axial sectioning. So once we section the pancreas from superior to inferior, we lay the slices on the paper towel and we number them. And we identify the possible slice which have the most possible tumor. So what we do is we're going to submit the entire slice of that, the entire slice of that pancreas, and then we, in addition, we also submit any possible tumor areas from each slice from the superior to inferior. In this way, we are mapping the tumor size based on the anterior and the posterior and the superior and the inferior. So 2-dimensional mapping of the tumor size. So we feel this is the possibly the most accurate way to measure tumor size microscopically. So how do we measure tumor size microscopically? So this comes recommendation number 3. The tumor size of treated Pdags should be measured microscopically as the largest dimension of tumor out limits that is bounded by viable tumor, including the intervening stroma. So here we show 3 different schemes. One is the part A is only one microscopic focus viable tumor. So only the viable tumor area should be measured as the final tumor size. So the part B shows the treated tumor bed with multiple foci of tumor. In this case, you measure the viable tumor size based on the out limit of that is bounded by the tumor, by the viable tumor. So in this case, it's measured from here to here. When you have tumor invading outside the tumor bed, you measure from similarly from the out limit of viable tumor side, tumor bounded area. So in this case, it's from here to here. So as you can see from this diagrams, the gross tumor size measurement can either overestimate or underestimate the tumor size of treated pancreatic ductal adenocarcinoma. So using this approach, we showed that the YPT stage does correlate with the patient survival, both at disease-free and overall survival. So more importantly, we showed that patients with a YPT1A and a YPT1D tumor have better survival in those with YPT1C tumor. However, there's no difference between YPT1C and the YPT2 tumors in either disease-free or overall survival. This suggests that the 1 centimeter tumor size may be a better cutoff for YPT2 in treated pancreatic carcinoma. Of course, this needs to be validated by future studies. The recommendation number 4 is again regarding the sampling. So a case should not be classified as complete pathologic response unless the entire pancreas, peripancreatic soft tissue, ampulla vata, bile duct, and duodenum adjacent pancreas are submitted for histological examination. So I want to give one example for such a case. So this is a 72-year-old man received for FOLFIRINOX neoadjuvant therapy and radiation. He underwent the Whipple resection. And grossly, the pancreas shows extensive fibrosis, but there's no mass lesion. So we submit the entire pancreas, peripancreatic soft tissue, bile duct, ampulla vata, and duodenum adjacent to pancreas. So in the pancreas, all we see is this extensive hyalinized fibrosis with a minimal residual pancreas tissue, but there's no viable tumor cells. So based on the pancreas sections, we can classify the tumor as the YPT0, CAP and MDS grading 0 response. However, in the duodenal sections, we found one microscopic focus of adenocarcinoma in the submucosa. So now the tumor stage changed to YPT1A and the CAP and MDS grading system 1. So you can see the sampling does change the tumor stage and also changes the tumor response grading. So what are the additional suggestions for the sampling of treated Pdag? First, for the small tumors, 2 centimeters or less, you submit the entire tumor for histological examination. For a larger tumor, more than 2 centimeters in size, we should perform generous sampling of the tumor. At least 2 sections per centimeter of the tumor should be submitted for histological examination. So when you have a pancreas resection, you cannot find a grossly identifiable tumor, or when you have submitted the initial representative sections from the possible tumor area, which have no viable pancreatic carcinoma. It is time for you to submit the entire pancreas with peripancreatic soft tissue or rigorous extensive sampling of the pancreas and the peripancreatic soft tissue with the bile duct, ampulla vata, and duodenum adjacent pancreas is recommended. So other sections from treated pancreatic carcinoma should be the same as the treatment-naive pancreatic carcinoma cases. This includes the margins, surface include anterior, posterior, and vein groove, and all lymph nodes. I want to quickly mention that minimal 12 lymph nodes are required for acute end staging for treated Pdag. So this is the same stage for treated Pdag as well. So of course, the other sections document the tumor involvement of peripancreatic soft tissue, bile duct, ampulla vata, adjacent duodenum wall, or other organs if applicable. And also, you want to have a representative section of the normal pancreas as well. So this is the same as the untreated pancreatic cases. So why do we support this extensive sampling approach for treated Pdag? Number one, as we mentioned earlier, the therapy-induced fibrosis is often so extensive in the treated Pdag. So in this way, it's really difficult to identify with certainty where the tumor is located, where the tumor starts, where the tumor ends. So that's why extensive sampling is important. Second is this kind of microscopic invasion. So this microscopic invasion, you can see either in the adjacent pancreas parenchyma or peripancreatic soft tissue. This kind of microscopic invasion can only be identified on histology by generous sampling. And another reason for general sampling approach is this heterogeneous response in different areas of the tumor. So this is the photos from a same case. And you can see some areas look like CAP grade 1 or MDS grade 1, CAP grade 2, MDS grade 2, or CAP grade 3, MDS grade 2 response. You can see all three of them in the same case in different areas of the tumor. So I want to use this case to demonstrate the importance of sampling. This is a 67-year-old man who received a neoadjuvant therapy and pancreatic duodenectomy. Grossly, we identify a 2.3 centimeter mass in the head of the pancreas, and we submit the entire mass in 10 sections. So in all the sections, we only identify 2 microscopic foci of the tumor. The first foci is in the left lower corner, which have a adenocarcinoma gland in the lobule. The second focus is ductal carcinoma. So if we based on the recommended protocol, and this tumor will be measured at 0.5 centimeter, which is YPT1A, and the CAP or MDS grading system will give a grade 1 response for this particular case. So we went back to the rest of to submit the entire pancreas, peripancreas soft tissue in 23 additional sections. So in these 23 additional sections, we identify 6 slides have tumor like shown here. So you can see from this slide, we see a significant more of residual tumor in the invading into the adjacent pancreas. The final tumor size measured based on the mapping section is 3.2 centimeter. We changed it from YPT1A to YPT2 based on tumor staging. The grading, tumor response grading changed from CAP or MDS grading 1 to CAP or MDS grading 2. In this particular case, you can see both parameters are important prognostic factors changed. So how does sampling affect survival? So right now we don't have data. This is a recent study we performed using the data set in our institution. We look at the complete sampling versus non-complete sampling in patients with MDS grading 0 or MDS grading 1 response. What we found is when the entire pancreas or peripancreatic soft tissue was submitted, patients have better survival compared with those without complete submission. So even though the p-value does not reach the statistical significance, but we can see a clear trend, the difference for the importance of the sampling. I think this we need to expand to include more patients in this study to confirm this finding. So let's look at tumor response grading system for treated Pdag. There are 3 major grading systems: the CAP grading system, the Evans grading system, and then the MDA grading system. The CAP grading system is based on the modified Ryan scheme, which is for rectal adenocarcinoma. So this is the same grading system also applied to esophageal cancer, gastric cancer, and rectal cancer. So in pancreas, there's no clinical data to support this system. Similarly, the Evans grading system also have no clinical data to support the prognostic significance of this grading system. Let's look at the CAP grading system first. So this is a very first study we published in Cancer in 2012, and to show that when the patient have CAP grade 0 response or CAP grade 1 response, they have much better survival compared with those with CAP grade 2 and CAP grade 3 response. However, we did not see any difference between CAP grade 2 and CAP grade 3 response. We did a follow-up study showed that the similar results, which is that the CAP grade 2 and CAP grade 3 have no difference in terms of either disease-free or overall survival in our study population. And on the other side, the CP grade 1 and CP grade 0 have much better survival. So this was confirmed by the study from the Royal North Shore in Australia. So you can see here in their study, they also document that the CP grade 2 and CP grade 3 have no different survival. So our result also confirmed by the study, large study of 341 patients from Medical College of Wisconsin. And you can see here, so this is a PR and NI is on the material method part. This is CP grade 2, this is CP grade 3. And you can see the CP grade 2 and the CP grade 3, again, shows no survival difference. But the CP grade 0 and CP grade 1 survival better compared with CP grade 2 and 3. So what we really need is a 3-tier grading system instead of the 4-tier CP grading system. So this is another study from the Japanese study group. What they showed is essentially the same result, showing that the CP grading 2 and 3 have no difference in survival. Similarly, they also showed the Evans grading 1A, 2B, 1, 2A, 2B have no difference in survival, either disease-free or overall survival, which is similar to our findings as well. So this is a most recent study from our institution, showing that when the patient received the modern regimens for neoadjuvant therapy, FOLFIRINOX and gemcitabine and nab-paclitaxel. So in this group patient, 284 patients, we see the same result as we observed before. The CP grade 1, CP grade 0, CP grade 1 have better survival compared with CP grade 2 and 3, but there's no difference in CP grade 2 and CP grade 3 in terms of survival, either disease-free or overall survival. So what we really need is a 3-tier grading system for treated pancreatic ductal carcinoma. So this again shows the Evans grading system from our database. That's Evans grading system. Evans grade 1, 2A, 2B have no difference, but the Evans grade 3 and Evans grade 4 have better survival compared with the other grades of patients. So this is a similar study from Royal North Shore. Again, it shows a similar finding that Evans grade 1, 2A, 2B have no difference, but the Evans grade 3 and 4 have better survival in their study. So what we really need is the 3-tier grading system. This is what we show for the MDS grading system. So you can see the MDS grade 0, MDS grade 1, MDS grade 2. So which define the grade 1 is 5%, less than 5% of viable tumors in the treated tumor bed. The grade 2 is 5% or more tumor cells in the treated tumor bed. So this is a very simple and simple grading system, and also very easy to use in daily practice. So this is our recent study showing the MDS grading system. Again, shows the correlation with better survival in both disease-free and overall survival in the modern therapy treated Pdag patients. So interestingly, a recent study from the Royal North Shore, and they call the RNS grading system. So in that grading system, they again is also 3 tiers. The grade 1 is 10% or less viable tumor cells. Grade 2, 11 to 75% viable tumor cells. Grade 3, 75% more than 75% of viable tumor cells. Well, they showed that they can further classify the CP grade, the CP grade 2 into 2 tiers based on the quantitative analysis. But this needs further validation from other groups. So how about the inter-observer concordance use different grading system? So this is a very first study to look at this particular issue. So this was from Toronto, Canada, University of Toronto in Canada. They reviewed 14 cases by 4 different pathologists, GI pathologists. What they found is when they use they observe only 14.3% concordant cases, 7.1 concordant cases in Evans using the Evans grading system, and 14.3 concordant cases in CAP grading system, but they observed 78.6% concordance when they use the MDA system. This shows, first study showed MDA system perform better in terms of inter-observer agreement. So after this study, there are several other studies. So you can see in every study, MDA system perform much better compared with CAP grading system. Especially when you look at when you have a large number of pathologists. In this particular case, 8 pathologists reviewed 30 cases. The CAP grading system only reached 13.3% of concordance, but MDA system reached 83.3%, which is much better compared with the CAP grading system. So more convincing study come recently from the international study group of pancreatic pathologists. So they reviewed 50 cases by 23 GI pathologists from 9 countries. The CAP grading system reached consensus in 9 of 50 group cases, 0%. But the MDA grading system reached 58% concordance in the 50 cases. So this again shows even with a large number of pathologists involved in this study, MDA grading system still have significantly better inter-observer concordance compared with the CAP grading system. So this comes recommendation number 5. MDA grading system for tumor response have better correlation with survival and have better inter-observer concordance among the pathologists than the CAP system. So based on this is the white paper recommended that the MDA grading system can be used as an alternative grading system for CAP cancer protocol. So why the CAP system performs poorly in terms of inter-observer agreement? I think the major problem is the defining criteria. So you can see the grade 1, single cells or very small groups of cancer cells. So there's no quantitative description, it's just descriptive. Similarly, grade 2, treated cancer with evident tumor regression, but more than single cells or rare groups of cancer cells. And the past grade 3, extensive radical cancers with no evidence of tumor regression. As I showed before, the treated tumor versus untreated tumor, there's a lot of overlap features. So this defining criteria leave a lot of room for the pathology to interpret. So that's why there's a lot of discrepancies in terms of when you apply CAP grading system to the neoadjuvant treated pancreatic cancer. I would just want to show this one particular picture. So this one, if you show it to me, I will say this tumor have reduced cellularity with hyalinized stroma with kind of some mixed order changes with the necrosis. I may give a CAP grade 2 for this particular picture. But some other people may look at this same picture and say, okay, this looks like not much response. They give a CAP grade 3. So this is where the problem comes with the CAP grading system. So this is why the consensus statement from the 2019 Amsterdam International Consensus Meeting suggests that the defining criteria for CAP grading system should be improved by replacing these subjective terms with objective criteria to evaluate the extent of viable tumor. So in conclusion, the systemic and standardized grossing and sampling protocol should be adopted for pancreatic specimens for treated Pdag. Consecutive mapping sections along the largest gross tumor dimension are recommended to validate tumor size by histology. The third is adequate sampling for treated Pdag is important for accurate tumor grading and tumor response. I hope my presentation convinced you that the sampling is critical for treated Pdag. A case should not be classified as a complete pathology response unless the entire pancreas, peripancreatic soft tissue, ampulla vata, common bile duct, and duodenum adjacent to pancreas are submitted for microscopic examination. Microscopically, the tumor size should be measured by as the large dimension of the tumor outer limit that is bounded by viable tumor cells, including the intervening stroma or intervening pancreas tissue. So the MDS grading system have superior inter-observer agreement and perform much better than the CAP grading system in predicting survival in treated Pdag patients. Therefore, MDS grading system may be used as an alternative grading system for the CAP cancer protocol. Lastly, our study suggests that tumor size for YPT2 should be 1.0 centimeter instead of 2.0 centimeter. With this finding is a further confirmation from other study groups. So before I end my talk, I want to briefly touch on the lymph node metastases. Lymph node metastases have been shown to be a robust prognostic factor for Pdag patients, both treated and untreated patients. So this data from our study group showed that the YPN staging correlated very nicely both at disease-free survival and overall survival. The lymph node metastasis can also show treatment response to neoadjuvant therapy. And in this case, you can see the lymph node shows fibrosis with scattered individual atypical cells, which is confirmed as by cytokeratin stain. These are the carcinoma cells. So this lymph node metastasis clearly shows a marked response to therapy. So the question remains, for the future studies, number one, how to integrate the tumor response in the lymph nodes metastasis into the grading system. Number two, how can we incorporate molecular and immunohistochemical markers in the pathological evaluation of treated Pdag? The last question, I think, is with the development of the artificial intelligence, how we use this new technology to into the pathological evaluation and the grading of tumor response. So I want to especially thank many people for this white paper. Firstly, the members of the neoadjuvant therapy, neoadjuvant working group of the pancreatic biliary pathology, members of the growing working group, the members of education committee, and the members of the executive committee. This is a great teamwork to get this white paper done. In particular, I want to thank all the members of the neoadjuvant working group. They spent a lot of time and put a lot of thought and effort into this white paper. I hope that more and more institutions will adopt this the recommendation from this white paper, so that in the future we can have standardized sampling and growing protocol for the treated pancreatic carcinoma. I will stop here, and I'll be happy to answer any of your questions. Thank you.
Thank you, Dr. Wang, for
Thank you.
Covering a very important and practical aspect, how to deal with pancreatic cancers which are already neoadjuvantly treated. So this Q&A session, we also have Dr. Wood, and sorry about the technical glitch during the last session, and thank you, Dr. Wood, for your patience and joining us again. So I will read the questions that you answered last time as well. So let's go back. I'm sorry about that. So the first question is that was from one of our viewers for your talk is that what are the important features that you would like to emphasize on a small biopsy for diagnosing pancreatic adenocarcinomas?
Yeah, I think on a small biopsy, you often have to rely more on the cytologic features and the architectural. I think, without a larger specimen, sometimes it can be challenging to appreciate the kind of growth pattern. But if you do happen to get lucky and get a gland next to an artery or a focus of invasion, perineural invasion, I think that can be very helpful. So I think you kind of have to take whatever features present themselves, but I think the cytologic features tend to be more reliable in small material. So the nuclear atypia, the luminal necrosis, incomplete lumina, those kind of features in a smaller biopsy.
Right. There was another question on smaller biopsies about how to diagnose large duct carcinomas on a small biopsy. And are there any clues that you would like to suggest?
Yeah, I think, again, that can be quite challenging. I think, and they can be challenging to tell them from IPMNs, but I think there, in some ways, you can rely a bit on the radiologic impression, because if they're not expecting a cyst and they're expecting a solid mass, then an IPMN is less likely. I think also like to highlight this SMAD4 immunohistochemistry, which can be helpful in challenging cases. If you have loss of SMAD4, that's quite suggestive of a pancreatic ductal adenocarcinoma rather than, a precancerous lesion or a benign process. The challenge with SMAD4 is that it's only lost in about half of pancreatic cancers, and so if you have it retained, it doesn't exclude cancer, but the loss can be really helpful in ruling in cancer.
Right. So regarding SMAD4, there was another question. Is SMAD4 retained in those patients without a gene mutation, or is it retained in tumors with mutation as well?
So SMAD4 is a tumor suppressor gene, and so it's often lost by homozygous deletion. In those cases, you do completely lose expression with the mutation. It can also have missense mutations, and those are kind of variable as to whether you lose expression. And so I think loss of SMAD4 is indicative of a SMAD4 alteration. I think retention does not exclude a missense mutation, but it's not really, the retention is not really helpful. It's only helpful if you lose it to say that there is a mutation.
Right. This was a question which has come somewhat similar, right? I mean, in a liver biopsy, which is suspected for pancreatic metastasis, and when they're not sure about metastasis from other regions as well in the GI tract, what is your practical suggestion?
Yeah, I mean, I think, unfortunately, there's no single stain that you can say 100% for sure it is pancreatic ductal adenocarcinoma. I think staining like an upper GI primary with CK7 can be helpful, but obviously that would be the same in a cholangiocarcinoma. I think loss of SMAD4 when you have it can be suggestive, but it can be less frequently lost in cholangiocarcinomas and colon cancers. And so again, it's not 100%. And I think some of it relies on the clinical suspicion as well.
Right. Is there any utility of CDX2 in that situation or no?
I mean, I think it depends on the clinical suspicion. It's uncommon in Pdag, but not never. And so I think if the question is, Pdag versus lower GI and it was CDX2 negative, that would support Pdag. But and again, TTF1 is kind of similar, that is usually negative in Pdag, but there are reports of positive cases. So for the lung differential, that can also be challenging.
Right.
Unfortunately, there's just not one, like there's not a pancreas stain. I wish there was.
Right. So there is, because that's always a practical problem, and many a time biopsies will just say that rule out primary, and they don't know, where the primary is.
Yeah, and I think that's where conversations with the clinicians can really help to say, just express to them the uncertainty in what we favor, but that, there's not 100% stain.
Right. So here's another question. What is your experience with S100P and P53 for large duct Pdag diagnosis?
We have not done S100. The S100P is not something we use clinically. For P53, I think that strong and diffuse nuclear staining again can be helpful to indicate a P53 mutation. I think you can have P53 mutations in IPMNs, and so that, unlike SMAD4, the P53 doesn't exclude an IPMN, but I think it can indicate a neoplasm with a P53 mutation.
I add something?
Yeah, of course.
So the S100P is, that's a study published by Dr. Wang from UCLA. They showed it's quite specific for pancreatic ductal carcinoma. It's not expressed in the chronic pancreatitis. But somehow this marker was not really adopted clinically. But we actually did some study as well on this protein. S1RP actually is a very good marker to differentiate the ductal carcinoma versus pancreatitis. But I don't know, for some reason, this marker was not adopted, not used very widely in the clinical practice.
Right. So, thank you. The next question is, do you require evidence of stromal invasion to diagnose Pdag? What if you just see detached neoplastic epithelium with SMAD4 loss?
I mean, I think it depends on the atypia in the epithelium, but I think if you had markedly atypical epithelium that was detached and had SMAD4 loss, as long as you had a good internal control, I think that's the other key part of SMAD4 IHC. It can be kind of finicky. And so I definitely would want to see a good internal control before calling it loss, but I think in that case you could.
Right. So this is a question that you answered last time, so we have to repeat it again. Sorry. The question is, how frequent is intestinal type differentiation in Pdag, especially when it is not IPMN related and it's not a colloid?
Yeah, not very common. There are in studies in the literature reports of CDX2 being positive, SAPB2 being positive in a minority of Pdag, so it's not a never, but I think it's not common. And I think if you see intestinal differentiation, you should always exclude either a duodenal or an ampullary primary.
Right. I think this question is for Dr. Wang. So this is about like a number of sections that you would like to recommend to submit for treated cancers, like neoadjuvant treated cancers. Do you recommend that the entire specimen should be submitted?
Well, it depends on the situation. I mean, there's as we mentioned in the consensus paper, if you just have a small tumor, which is 2 centimeters or less, the common recommendation is you submit the entire tumor for histologic examination. But if you have a larger tumor, which is 2 centimeters or above, you can do representative sampling. However, in the case if you have a pancreatectomy, you cannot see a tumor after neoadjuvant therapy. In that case, we strongly recommend to submit the entire pancreas, at least the entire pancreas for histologic examination. In the case of if you submitted the pancreas, like the case I showed in my talk, if you just show very limited number of foci tumor, in that case, sometimes it's worthwhile to go back to submit additional sections. You may find much more invasive carcinoma in the pancreas in that case. So it really depends on the situation. I think the tumor size, the growth examination, and also your histology, initial representative section of the from the tumor. If you don't have tumor in the initial section, I think it's worthwhile to go back to submit the entire pancreas in that case.
Right. And as you said in your talk that in neoadjuvant treated patients, it is either oversized or it can be undersized on gross examination, right? But it is most probably oversized on gross examination when more areas are looking indurated and looks like tumor, right? Yeah, because the treated tumor is just diffuse fibrotic. It's very hard to see where the tumor really is. So a lot of times, personally, I will kind of rely more on the palpation. So when I cut the pancreas slice, I'll kind of palpate where the most likely tumor will be, and then I'll sample the entire slice from that area if I have a tumor. But sometimes you can easily miss the microscopic tumor in the adjacent pancreas or peripancreatic soft tissue. So in that case, really the sampling is really important for identify the viable tumors in those settings. Right. At least probably like practically speaking, that at least it is important to submit sections from an indurated area from both the edges, so that we do not miss anything like which might be the maximum size of the tumor, right? Yes, I think actually if you look at our paper, we kind of recommend that you kind of submit one side from the large dimension of the gross tumor all the way to the other side of the pancreas edge. So you can have an entire cross section of the possible tumor areas. So then after histologic examination, you can reassemble the tumor by putting the HE section together. So that way you can reconstruct the tumor
for tumor area and then you measure that way. You will definitely surprised to see how often you see some microscopic tumor beyond, invaded way beyond where you can see grossly.
Right, right. So in this case, I guess like as you suggested about slicing, so maybe we should do something similar to what is done for breast lumpectomy specimens, right? And if needed, one can go back and submit more.
Yeah, that's what we are doing right now, actually, because I think is given the current the agency staging based on tumor size, I think that for the treated pancreatic cancer, it's almost impossible to measure accurately by the growth. So that's what we are trying to do right now. We're kind of doing the mapping sections from the slices. If possible, I would recommend that way.
Right. No, thank you. That's, I think, very important for all of us who are reporting treated pancreatic cancers. So this question is for Dr. Wood. For p53 immunostaining, do you also consider null pattern of expression in favor of Pdag or just an overexpression?
Yeah, I think no would be as well. Thank you for pointing that out. I think most commonly we see the overexpression, but I think if you see a null pattern with a good internal control, I think that's also strongly suggestive. Thank you for that question.
Right. So again, like in continuation with your answer, Dr. Wang, there is another question that is serial sectioning superior than braid lobe sectioning along the long axis?
We are doing, it depends on how you cut the pancreas. There's two ways to cut the pancreas, either do bivalving. So that way you are basically bivalve the pancreas, along the two duct plane to ampulla vata. So in that case, you can kind of do coronal sectioning after bivalving. So in our case, right now, we kind of, in order to deal with the tumor size measurement, right now we switch to axial sectioning. So axial sectioning is we cut from the superior to inferior. So you have each intact slices, like the breast, mapping. So we think that's probably can give us a better, measurement for the tumor size. But if you do bivalving, I think you can use the coronal sectioning. I think it depends, use a similar approach. They bivalve the pancreas first, and then they do kind of coronal sectioning, kind of perpendicular to the axis of the pancreas. So that one also give a good mapping, strategy for submitting the sections and also for mapping the tumor.
Right. So this was somewhat related with axial grossing. There was a question that with axial grossing, is the uncinate/SMA margin submitted separately before slicing, or does it remain part of the sliced specimen? So this can be taken by either of you, I guess.
We do that way is we do axial sectioning, and after axial sectioning, because we ink the specimen first, we know where the uncinate margin is. So after the axial sectioning, we kind of take that one we submit the entire the uncinate margin perpendicularly from the sliced pancreas after sectioning.
Right. So I think that as far as the different methods of grossing is concerned, so as long as it is adequate, so there is probably no recommendation that which one is superior than the other, right? So,
yeah, right now we don't have enough data to support whether bivalving is better versus axial sectioning better. The consensus paper also did not come up with a recommendation. It really depends on how comfortable the pathologist would like to use. Either method works fine. I think the major thing is sampling the mapping of the section you submitted.
Right. So there was one question about use of mega blocks. Do you recommend the use of mega blocks for post neoadjuvant treated Pdags?
Well, that would be ideal if we can do that. I see some institutions do the whole mount sectioning, but that's not many places can do that. That means that's just a kind of not many academic institutions have those facilities to do the whole mount sectioning. I mean, that would be ideal if we can do the whole mount sectioning of the pancreas. So that will give us the best estimate of the tumor, best measurement of tumor size. But the very few places can do that.
Right. So this question I saw about lymph nodes in patients who are treated if you see on lymph nodes, there is treatment-related change, but there are no neoplastic cells. What do you do? We understand that you don't count them as positive, but do you mention that how many lymph nodes have treatment-related changes, or what is your approach?
So in our practice, the things like if you just have one lymph node have those fibrosis. I'm sorry, if you don't have any other lymph node, positive lymph node, you just have that lymph node have fibrosis. In other settings, you may worthwhile to do some additional sectioning to document that's really truly negative for carcinoma. If necessary, you can do a keratin as well to rule out metastatic carcinoma. If you have positive lymph node in that settings, that documentation may not be that critical. So you can based on if there's no tumor, I normally to say that how many lymph nodes with fibrosis, which most likely represent metastatic carcinoma with treatment effect.
Right. So that means that what you want to emphasize in the last sentence, if I got it right, that even if lymph nodes are positive, and you would still mention how many lymph nodes have treatment-related changes. Is that correct?
Yes, I think we saw that in the rectal cancer, we saw that in the esophageal cancer as well. So sometimes you just see a cellular mucin pulse or just fibrosis with histiocytic infiltrate or inflammation, but you don't have viable tumor cells, even you cut additional levels or keratin stents. In other settings, I would document we see how many lymph nodes with fibrosis, with mucin, with this most likely represent metastatic adenocarcinoma with treatment effect. At least to give a clinician, let the clinician know that could be possibly, before the neoadjuvant therapy, the patient have whatever end stage based on that number of nodes.
Right. Yeah, I think there's a related question about acellular mucin. This can be taken by Dr. Wood, that if acellular stromal mucin is identified at the leading edge of an IPMN with invasive cancer, will you consider it positive, considering the caveat that acellular mucin is also seen in non-invasive IPMN?
Sorry, is this a question about the margin?
Yeah, if there is acellular stromal mucin at the margin.
Of a otherwise non-invasive IPMN?
Yeah, invasive IPMN.
Invasive IPMN.
Yeah, IPMN with invasive cancer, yeah.
I think kind of like Dr. Wang said, that I think if you don't have neoplastic cells in it, it's not positive, but it is perhaps suggestive, and I would cut levels, just to make sure that nothing pops up. But I think if you do your due diligence and there's no cells in it, then that's not cancer. But I would still include that as a comment in the report.
Right. Yeah, there was a very related question on this, that in a Pdag, whether it is treated or not, and if it is sent for frozen section and we see only acellular mucin at the margin, like whether it is unseated or the pancreatic neck margin. So how do you comment them?
So I think that's, for me, I think it's really kind of very critical in that setting. So you communicate with the surgeon very clearly. So just tell them, I think at the least we should cut levels on the frozen section to see if any residual tumor in that section. If you really after you cut a section of the frozen, cut the deepest levels of the frozen section, you still just see mucin. In that case, I'll still report back to the clinician. And also depend on if you just have IPMN with mucin may not mean as much as if you have ductal carcinoma with mucin. Right. So that's something I think is you have to communicate very clearly with the surgeon and see what our finding is, what our concern, and then let the surgeon make the final decision.
Right, so that's important. I guess so undercalling is also very important, right? So that at least we just not call it negative straight away on frozen section, correct?
No, I would not do that.
Right.
I agree.
Thank you. I think that would be very important to know for all of us. So here's the next question. So this is about to Dr. Wood, that is hepatoid carcinoma arising from intraductal oncocytic papillary neoplasm? What's your comment on that?
No, I think that's oncocytic carcinoma. I think again they can stain with Hep-R, but I think if you have a IOPN and then you have a carcinoma arising from that, I don't think that's the same as hepatoid carcinoma.
Right. So here is another question for you, Dr. Wood. How can we differentiate the primary signet ring cell carcinoma of the pancreas from the invading or metastasis from other organs, such as from stomach?
Yeah, I mean, I think, the two that come to mind for that, for really just cohesive carcinomas are stomach or breast. And I think for breast, it's in some ways easier because you can do ER/PR. I think for stomach, again, there's not a single immunostain that really helps because pancreas can uncommonly have CDX2, SATB2, and they're not actually that common in gastric carcinomas either. So I think you rely a lot on the clinical. I mean, signet ring cell carcinoma of the stomach is far, far more common than signet ring cell carcinoma of the pancreas. So if you have lesions in both places, I think the odds are that it's the stomach meting to the pancreas rather than the other way.
Right, right. So this is another one. In patients with history of treated pancreatic cancer who present with recurrence at a distant organ, what are your preferred stains to rule out pancreatic mass? I think we have discussed that, right? But still,
I think we did, but I don't remember if it was when the sound wasn't working.
Oh, I guess so.
Yeah, so I think that unfortunately, there's not a single stain. I think, staining like upper GI pancreatobiliary with CK7 can be helpful. I think loss of SMAD4 is helpful, but not entirely specific because you can also lose it in a smaller portion of cholangiomas.
Right. So this is another basic question regarding grossing, whether it is neoadjuvant or not, that how many sections would you recommend to be submitted from a non-neoadjuvant treated cancer? Do you want the entire to be submitted or representative? Either one of you can answer that.
I think for us is, because, in our institution, the situation is different because we have 95% of the pancreatic ductal carcinoma is treated.
Right.
We only have like about 5% of them are not treated. For us, the untreated carcinomas, we submit entirely. We don't give any option. So because it's mainly for preserving the tissue for future studies, it's not for diagnosis purpose. I think from the tumor staging diagnosis purpose, I think representative sectioning should be fine in the untreated cases if you have a clear-cut mass lesion in the pancreas.
Right. I mean, this might be important. Yeah. Sorry. Yeah, Dr. Wood, you wanted to say something?
No, I was just going to say I 100% agree.
Yeah, because this might be an important thing to consider for our viewers who might be in areas where it might not be possible for them to submit all the sections, right? Okay, so
I mean, I think diagnostically, as Dr. Wang said, diagnostically representative is fine for an untreated cancer.
Right. And another grossing related question, what about the pancreatic groove margin? Is it considered a true margin? And again, what about anterior and posterior margins? Are they considered true margins as well?
So you are talking about the vein groove?
Yeah.
I mean, right now the CT protocol does not consider as those vein groove or the anterior posterior surfaces. They are considered as surfaces. They are not considered as a margin by the current CT protocol.
Right.
So I think that's also at this point we really don't have any data to support how important those surfaces, positivity of those surfaces, correlate with the survival. There's also a lot of variations. Some places will consider, tumor is less than 1 millimeter from that surface considered as positive. Some people consider as only at the surface positive. So that's a lot of variations in that area. I think those areas need a future study to really document how important those surfaces are in the clinical, management and the patient prognosis. But at this point, we don't have data. And also the standard protocol right now is recommend those one documented as surfaces. You don't report that as a margin.
Right. I mean, this is no matter how often we discuss it, and even sometimes this question comes from the surgeons that why there was no mention about the pancreatic groove, and we have to reiterate that no, this is not considered as because of course it should not be a margin, right?
Yeah, because sometimes encounter some cases, some people report the case as a possible margin. So the surgeon was come back to the group, make a big deal of it, said, this based on the current protocol, it's defined as a surface. Not defined as a margin. So the margin, they only consider in the pancreas head, the only incidental margin, the pancreatic parenchymal margin, and the bile duct margin. If you have a superior mesentéric vein resection, the vein margin also should be included. But other than that, the rest of the groove anterior, posterior is only regarded as surfaces, not really as margins based on the current protocol.
Right.
It really highlights how important it is to communicate with your clinician so that whatever terms you put in their report, they know what you mean, right?
Yes.
Right. Yeah, I think we have one last question. So this is about the grading system that you have talked about different grading systems for reporting treated cancers, Dr. Wang, and what is your recommendation or what is the consensus that which grading system should be included in the report? Is there a CAP guideline on that?
Because as I mentioned in the our white paper, we prefer to use the ambient system, because if you look at the patient survival data, you look at the from multiple institutions, and also if you look at the inter-observer agreement, in terms of CAP grading versus ambient grading system definitely work better compared with the CAP grading system. So the major issue is because that CAP protocol, we cannot fight with that, right? So we still continue using the CAP protocol, but we think the CAP protocol also included that ambient system can be used as an alternative, grading system. I think that both systems should be okay. But as I mentioned in my talk, the CAP grading system, the grade 2 and grade 3, it really showed no separation in the survival in the multiple studies. So, I mean, the point is whether you want a 3 grading system or whether you want a 4-tier grading system. So some people argue that, the 4-tier grading system will provide us, more information in terms of tumor response. But, in that case, because right now we don't have a good criteria to separate the CAP grade 2 versus CAP grade 3 at this point. So I think that's really is a kind of gray line at this point. I think, the consensus still want to favor a 4-tier grading system, but right now we don't have a good cutoff area to cutoff value for separate the CAP grade 2 versus CAP grade 3. So that's why they didn't show good correlation with survival. They also have very poor inter-observer agreement in this settings.
Dr. Wood, do you have any comment on this?
I totally agree. I think that the CAP grading system is the standard, but it isn't perfect. And again, I feel like I keep saying the same thing, but the important thing is for your clinicians to know which system you're using so that they know how to interpret whatever scoring system you put in.
Right. Seems like moving forward, maybe we will see 2 separate CAP protocol for treated and non-treated pancreatic cancer reporting, right?
Yeah, I think right now they are integrated together. So, I mean, I don't know if I think right now the system, the CAP protocol works okay to the system. The major thing depends on how to. I mean, in terms of the grading system, that's a major one of the major issues that we have.
Right. Actually, we have viewers from so many different countries, and I mean, even though we take the synoptic reporting as granted, and I mean, you would be surprised to know that not in many countries that we have actually synoptic reporting. So, I mean, I think those probably our viewers who are not used to the CAP protocol and the synoptic system, it's a time that maybe like you can at least include the CAP protocol in your report. That would be very helpful for maintaining quality, I guess, and providing proper reporting. So there is one question that is coming up for a second time, Dr. Wang. I think this would be the last question. This is from Dr. Boris Janssen from Netherlands. That have you already made any progress on AI for tumor response scoring?
We have not really do that. We have the samples. We have not really started working on that. I think that will be something in the future, definitely doable in the future.
Right.
That's a great question. I think Dr. Johnson, he already done some study with in the AI areas. Is proof the AI is feasible to separate the treated versus in the future. Definitely, I think those. I think it's a very good starting point. I mean, the major thing is how can we apply this especially in the age of digital pathology. I think that will be coming sooner or later with the AI technology combination with the digital pathology. That will be something in the future good direction to go.
I agree, and I just want to say I think AI approaches are much better than humans at quantifying things. Like
Right.
humans are not, we don't like counting. We're not great at that. So I think any task that requires us to either count or quantify area, I think that's just like asking for AI to help out. So I think that could be a great place for it.
So is there any progress at Hopkins from your side, Dr. Wood?
We haven't looked at that question specifically. We've been working with colleagues in engineering to develop machine learning approaches for just general annotation in the pancreas, more for research applications and to do 3D reconstruction and other things. But we haven't applied it to treated or untreated cancers. But I mean, it's certainly something we'd be interested in.
Right. No, thank you so much.
So, Hamin, we should talk.
Yes, right, definitely. Yes, this is a very good area. If I see you guys did an amazing job to do the 3D modeling for the pain lesions. Those are beautiful work. I think in the future, definitely, there's a lot of things that can develop in that direction.
I think with that, I think we have come to the QA session, come to the end of the QA session, and also the end of this 2-day course on pancreatic pathology. And we would like to thank Dr. Wang for this excellent talk, and Dr. Wood for your talk as well, and coming back, Dr. Wood, to take the QA session. Sorry about that, and thanks for your question. And we would also like to thank the Pancreatic Pathology Society for helping us organize this 2-day talk on pancreatic pathology. That is excellent, and we really appreciate it. And you would be happy to know that we had so many viewers, take over a couple hundred viewers from different parts of the world who joined for your talks. And I could keep track of our colleagues who joined from as far as Cambodia, Brazil, Ukraine, Somalia, Turkey, India, Hungary, to name a few. Thanks to all of our viewers, and thanks everyone, and thank you all for joining us.
Thank you.
Good night.
Thank you.
Thank you.